when it comes to specific sperm things, when you're actually actively trying to conceive, then you don't want to be in a sauna or a jacuzzi. And again, the average man, from the time the sperm start dividing until he ejaculates them, it's a continuous process. It's like a cookie factory. Is about 3 months. So you can't like say, oh, my wife is fertile this weekend, I'm not going to smoke for the next 2 days. That doesn't work.
When my heart stops, not a second sooner, I'm gonna finish what I've begun. 'Cause my heart's got a reason to believe in me and a dream and whatever may come. And as long as I'm breathing, I'll keep believing that I'm not done until my heart stops.
Hi everyone, it's Beth, your favorite therapist, or at least I hope I am, and host of Quiet the Clock. I am so excited to share the secret of my glowing skin with all of you. Lumine Face Pro. This amazing device has completely transformed my skin, and I've noticed a real difference in tone and texture in such a short amount of time. Lumine Face Pro uses advanced microcurrent technology to gently stimulate your facial muscles, promoting collagen production and improving skin elasticity. I mean, amazing. The device is also equipped with LED light therapy, which helps reduce wrinkles and fine lines and promotes cell regeneration. Hello, so perfect for this 43-year-old mama. I need every ounce of this. With regular use, Lumine Face Pro can help you achieve a smoother, brighter, and more even skin tone. It's so easy to use and safe on any skin type. Invest in your skin and experience the difference with Lumine Face Pro. Visit blumine.com today to learn more and order yours. Use the code QTC at checkout to get $30 off your first order. I mean, what a deal. $30 off your first order. I hope you guys run to blumine.com and get yours and love it as much as I do. Well, welcome back, everybody, to this episode of Quiet the Clock. I'm super excited to have our next guest, Dr. Werner, medical director and founder of Maze Men's Health. We were talking a little bit offline before we hit record that this is our first doctor where we will be able to ask questions about male fertility and infertility, which I think is such an important question. I think everyone that listens knows, I think we have just such an educational gap when it comes to health and fertility overall. And we have not talked about men's fertility, which I think is hugely important. So I appreciate you being here and welcome to Quiet the Clock.
Thank you so much.
Can you share, just before we jump in, because I have tons of questions, just give a little background about yourself and the work that you do.
So I am a urologist, and then I did a fellowship in male infertility and male and female sexual dysfunction. And then after my fellowship, so I had 8 years of post-medical training, which was ridiculous and much of it unnecessary, but that's the price you pay. But then opened my own practice. And at this point, we have a lab that does very sophisticated semen analyses. In fact, we have a procedure, which we can talk about later, where we're the only ones in the country doing. So we have people with azoospermia coming really from actually sort of all over the world at this point. Wow. So that's sort of cool. So I have a lab. We have the men's team where we see men with infertility and sexual dysfunction. And then we have the women's team where we treat women with sexual dysfunction. We are also, not to be a total bragger, but we're also sort of like one of the world centers for vaginismus, which we can get into. And so we're busy. It's fun.
Yeah, incredible. And I just saw you guys recently saw your, was it 50,000th patient?
Yes.
So what's it about that? Yeah. Amazing. Well, it sounds like you're doing really incredible things. I kind of want to just dive into the questions because I think there's a lot to talk about and a lot to understand. You've been practicing a long time. What have you seen in the landscape of male infertility in terms of just common causes?
So some of it's really unexplained. It's interesting that, whenever we look at infertility historically, the breakdown used to be that it was considered 40% mostly male factor, 40% mostly female factor, and then 20%, combination. The field has changed dramatically since I've been in practice. I think that really the main things have been that IVF, more on some of them on the women's side, which is that IVF became dramatically cheaper and better and more successful. So that meant that we didn't ignore the men, but getting a few extra points on the men's side may not be worth it the way it used to be. The way I break down infertility when I'm trying to explain it to couples, which they have found useful over the years, is very simplistic. As let's say it takes 100 points to conceive. So some points come from the woman, some points come from the man. Obviously, no one has 100 points, except Dolly the sheep, I guess, which I've never said before. Anyway, so who was cloned. So whenever we have a couple that has subfertility or secondary infertility, then the question is, how do we get extra points? And so there's really three ways of approaching that. So one is to see what's going on with the man. What is his baseline? So you always need more than one semen analysis. And if it's suboptimal, what can you do to improve it? Two is to do the evaluation on the women, and obviously that's in some ways more extensive. You're looking at hormones, you're looking at uterine cavity, you're looking at tubes. So, and then see if there's anything that we can do to improve that. Those are your best points, right? Because let's say that we find that we can dramatically improve the man's semen analysis, then for every cycle that they try to conceive, both for baby number one, and many people are interested in baby 2, 3, 4, or if it's secondary infertility, then those points will be added in, right? Because we've made a permanent change. If a woman has blocked tubes or a uterine polyp, then when we fix that, then for every cycle they try to conceive, then that kicks in. If we've maximized them both and we're not expecting them to get pregnant, or they're not achieving a pregnancy, then that's when we get the extra points in any given cycle, really focusing on the women, the idea being to get her to make more eggs, and that's usually hormonal, and to get the man's sperm closer to the eggs. So I know this is very basic, but it's just a good framework for looking at it. So you can do IUIs, taking the sperm, washing them, and putting the uterus, or you can do in vitro fertilization, taking the eggs out, putting the sperm with the eggs. So we're always trying to balance two things when we're trying to achieve a pregnancy. We're trying to get the woman pregnant as quickly as possible, but with the least amount of intervention as possible. So you're weighing those two things, right? And so it depends on the situation. If you have a 24-year-old woman and the husband has a big male factor and you can reverse it, or improve it, then that's the way you should go. If you have a 42-year-old woman and there's just small things you can do for the guy, then you may not want to spend that time, and you may decide that you're going to go to an IVF quicker, because anything we do with the men, sperm takes about 3 months to be made. So it takes 4 to 6 months to see the improvement. And that improvement may not be worth the time that you are, pushing back the whole schedule.
Right.
So that's my rubric, the way I look at it. And that sort of helps people make their decisions.
I love that. I love it being a conversation of both parties, because it can feel largely female skewed, that the conversation around fertility is like, we're going to just look at the woman first and test her first. And it's interesting to hear the percentage of 40% man, 40% women, because I feel like the landscape right now feels like it's a woman's problem.
Right. Well, that's historic. I mean, that goes way back to probably prehistoric man, So, I mean, it's been, yes, that's the way society has treated this whole issue. I will say, to everyone's credit, when I started my practice, they would indeed do the full, much more invasive evaluation on the woman before the man even got a semen analysis. So you had this whole thing where these young women were having full evaluations, and then the man turned out to have zero. And it was like, and the men were refusing to do it. And now you will see that that is not acceptable anymore. I mean, if a woman starts presenting to her regular OBGYN, they will say, these are your first tests and he needs a semen analysis. It's very rare that we see where the woman's got through her whole evaluation and then we find out that there's a real fundamental problem with the guy.
Yeah, I mean, I shared with you a little bit about my secondary infertility. So, once you're kind of in that camp, you're so connected to other women and communities of women that are going through that. And unfortunately, I know so many women, and I wonder if you see this in your practice as well, and maybe not, because it sounds like, again, it's a more holistic workup for both parties. There is this reluctance for men to be tested. I personally know friends and people that to get their male partner in for testing has been difficult. And I'm curious if you see that, or there's ways that, to have conversations around that.
Yeah, of course, I don't see that as much because they've already come into me, but I don't really see it because I always get whenever I meet with a couple, I really almost insist that the woman be there because they are 90% of the time driving this train to the men's discredit, really. So, and I find that the men are not, as a group, and that's especially if they already have one child, are not following this nearly as closely or as passionately. I've had people say, like, why, I always have a question, why are you here today? And they will say, my wife told me to come. It's like, and I'm like, okay, but that's not, sometimes I'll actually put the wife on the phone and I really push to have them here. And I really push, one of my dictums, which is, I'm sort of sexist in a pro-woman sense, is that I always feel that the women get to decide how many children the couple's got.
I love that.
I just do. I feel like, in general, we are still built biologically different, and women are very clear how many children they need to feel fulfilled.
Yeah.
And you do not want to mess with that. They will resent you forever. So whenever I get like the guys who come in and they're on wife number 2, and she says, well, I think I just want one. And I'm like, I look at the guy, it's like, she's going to want 2. It's like there are very few women who want a child and really want just one. There are, but you're the minority and you're going to do what she says. I don't care if you have 3 other from your first wife. You married her, and now it's, kick in. So
I love that. I think there's obviously like more of this emotional component too. And I have so many women that reach out to me because one of the things we talk about too is misalignment in timelines, misalignment in desired outcome goals, whether it's, marriage or family size. And I'm like, make sure if you want multiple, make sure they want multiple, because it's a difficult conversation. And and the time piece creates a lot of anxiety. If you're having to have that conversation over a year or 2 years to get aligned, it's very difficult.
Yeah, I'm a very black and white guy with this because, first of all, I'm obsessed with having children. And so that's why I went into this field. MAYS actually stands for Matthew, Adam, Zach, and Evan. So those are our 4 boys who are now in their 30s.
Oh my gosh, that's amazing.
My wife named it. And we were like, we definitely... We thought we wanted 6 when we started, and then, our kids were a little difficult, and they were children, in general. So, and then I actually got sick after number 3, and I went down to 0 sperm, and we thought that, and then we were like, okay, my wife definitely wanted 4, and I definitely wanted 4. And we were like, okay, we're just going to do donor and sperm. I did pop back, and so number 4 actually is the one who's the most like me. It's a little crazy, but I was very open to it at that point because we just wanted. And then after 4, we were desperate for number 4, and then my wife was like, done. Like, it's not even in the cards to have the next one. It's so fascinating. It's desperate and then done is often the pattern that I see.
Oh, yeah, desperate and then done. Yeah. Oh gosh, desperation is a huge piece of this. In terms of like lifestyle factors or health conditions that can impact male fertility, what are some of those? I know for myself, I learned so much for myself and my own fertility about, major lifestyle changes, got rid of a lot of toxins. Does this kind of the same lifestyle things apply for men and male fertility as well?
Well, it does. I mean, I think as we go through this process, we're finding that we're compensating more and more with IVF or advanced reproductive, techniques for the women because they're much better and they're much cheaper. And women, the average woman, at least in this area, is much older when she starts having number 1, 2, 3, or 4. So fertility rates you have to be very conscious of time, and especially if the advantage is not to push IVF, but I can because it's not my area. I will often lean towards that, not because, I want to fill women's bodies with chemicals, but I do feel that in general, what's going to make them happiest is the most likely way of getting the number of children that they want. And a month or two of the hormones is not as big as feeling that whole. So that's sort of the way I look at it. And again, every woman gets to make her own choice. But the advantages now of the IVF are that it's much more successful. And if a woman's having it at 38, 39, 41, 42, then let's say that she's starting at that age, then, and let's say she gets pregnant and not having done an IVF, then the next time she tries to get pregnant, she's usually 2 years older, which means that her chances are dramatically less statistically, as opposed to the success of a particular embryo is mostly based on the age of the woman when the embryo was created. So they'll now stack a few embryos and then they can put them back when the woman's ready. So I sort of feel that it's a more pro-women position to be aggressive up front and make sure they get what they want in terms of the numbers and health of their children. So that's just that's an attitude shift. Obviously, it's very different if you start at 30 and you want 2 children, you should not go right to an IVF, but so that's sort of in terms of the health, what's happening now with male infertility is we're getting a lot of the men who are zeros who come in and they have no sperm in the ejaculate. And that is 10% of all male infertility and 1% of all men. So it's actually a pretty common phenomena. Obviously, it's very distressing for couples, and it's intellectually puzzling because every man who has no sperm still had a father who had sperm, whether the father they think is their father or not. They still had a biological father who contributed sperm, and now they don't have any. So, and we don't, some reasons we understand and other reasons we don't. So that's a lot of what we do now in male infertility is trying to help make men make sperm or to find the low levels of sperm that might be there but not coming out in the ejaculate.
And then, so what are some of the treatments for men?
So let's focus in on the azospermic men, I think so first many of the men are coming in having been on testosterone replacement therapy without having been told that that's going to shut down their sperm production. So that's actually a great one because I can reverse that, right? So that's but it is pretty crazy that the men are started by these, I have a sort of bias against the injection clinics and things like that. They just don't tell the men,
Wow.
And so if we're going to do that, then I always have the men bank, or I certainly let them know that they're, to be aware of the fact that this is going to happen, because once they start if they need the testosterone replacement and they start on it, they feel dramatically better. And when you take them off of it, and even if when you make them make their own testosterone with Clomid, HCG, they don't feel good at all. They're miserable. So it's much better to bank it before we start.
That's so interesting. I didn't realize that you would use Clomid and HCG with men.
Yeah, because what it's doing is I mean, not to be technical, but in order to make sperm, the man has to be making the testosterone himself in the testes. You have 10 times the concentration in the testes when you're making it in the testes themselves than in the circulation. So the analogy I give is, if your testes are your boiler and then you put electric heat in, then it shuts down your boiler. It's still warm in the house, but you're not going to be making sperm or good numbers of sperm. And what the Clomid and HCG does is it stimulates, it ups the thermostat, the Clomid, and the HCG basically is like sitting on the boiler pressing the button.
Wow. I'm truly fascinated. Do you have one of the narratives, and you probably know this as well, but one of the narratives that women hold is sort of this, why didn't anyone tell me, right? I feel like there's, again, so many gaps in sort of in information and education. And just to hear what you said about men starting testosterone without being informed what it would do to sperm, do you have then men saying, like, having the same narrative or frustration, like, why didn't anyone tell me this?
Yes. And I think it's, there's a lot of sloppy testosterone replacement therapy going on in a not very medical, ethical setting. So the most interesting one, which is really non sequitur for this, but is for a long time, if the men were in their 20s and had low testosterone and lots of symptoms, I wouldn't start them on the testosterone because, I felt like they needed, many of them wanted children. And so why would I shut them down? However, the men with these low testosterone, their lives were on hold. Some of them had such low testosterone levels that they had no libidos, no energy, no ability to exercise. And so their lives were really stalled out. So I would say that's one of the changes I made in the last 10 years is that those men who are really suffering, I'm a little less paternalistic and I will bank them and then start them on the testosterone so they can move on with their lives. And then with full knowledge, they have the option that they can either reverse it, they'll be miserable, or they can use the bank sperm.
Oh my gosh, that's also so interesting. I guess, not as extensive for women as freezing their eggs, but this idea that they can freeze the sperm, bank the sperm, and kind of move on with life.
And it is the same thing as women banking their eggs, that the sperm of younger men have less mutations and work better than the sperm of older men.
Okay, so let's talk about that, because I think that's, I don't know if that's as well known as much of a narrative as this women having this biological clock. I feel like there is a narrative out there that like men can have children at any age.
So that is true, right? They can, there's, many men will still be making sperm way before they can put it in the right place, so to speak. But at the same time, the quality of the sperm is lower and the number of mutations in that sperm is much higher. And you do see a lot of neurologic and diseases, a higher incidence in the children of older men. If you just do a look, if you think about the number of older men who have autistic children, nothing to do with vaccines, obviously, there's definitely changes that happen as the men get older. So some of the men actually, and this is, I wouldn't say it's out there, I think it's supported by the science, is that we will actually, if they're reached, just like women bank their eggs, if a man is not anticipating to have children by the time he's late 30s, 40s, then I will, if they're my patients, I will suggest they bank the sperm. And I would rather use that sperm than that's been frozen, and you don't get mutations when it's frozen the same amount. And I'd rather use those.
Oh, I think that's I haven't heard that before. I think that's incredible. And I don't think that's like a strong narrative that's out there, at least in the fertility world, that there are considerations for health of the child when the sperm is older, and that there is this option to bank in the same way that women do. I mean, it's such in the best way possible, it is such a prevalent conversation among women now about egg freezing. And when I froze my eggs at 37, I'm 44 now, no one was talking about it. And very few people were doing it, or at least that I knew. And now it's just such a strong conversation and option and choice. Again, there's accessibility and cost, but so many more women are talking about it, but I've never heard banking sperm as an option for men.
Right. What we do. Yeah. Like, for example, my number 2, so that's A in May's, Adam, is gay. So since I knew the only way he was going to have biological children was to do surrogacy, and so he's going to have to do an IVF anyway, and he wasn't going to be able to do it with ejaculated sperm. So we froze him in his late 20s. Like, why not?
Why not? Yeah. Why not? Wow. Super incredible. How many men are kind of open to that suggestion when you meet with them?
Well, more and more. If you're sophisticated enough to be living in this area and finding your way to my practice, then you're more open to listening to what I have to say. But I don't think it's not standardly recommended. I happen to have a very large sperm bank. I don't do donor sperm, but I do designated donor sperm, meaning that, for gay men during surrogacy, or for women who want a specific donor, then there's very strict rules about the fact that they have to be tested, quarantined, retested. And that's just, a huge amount of paperwork and oversight by both the New York State and the FDA. And so there's not many people doing that, and that we do. And that's sort of a passion project for me, because having a gay son and, and a very queer family. So, it makes sense that many women would want to choose a particular partner who's not obviously their sexually intimate partner.
Sure. Yeah. Access and option. Beautiful. What are some other things that men can do, in terms of preserving their own fertility? I think, again, the conversation skews a lot towards women. There's so much information out there about what women can do to help egg quality, or what they can do to take care of themselves. Are there other things that you would want men to know that are listening that maybe aren't, one, we're talking about banking sperm, but maybe that's not the place that they're in yet? Are there things they can do or think about now to preserve sperm health?
Yeah, the nice thing about there's nothing magic. Health is sort of, it's like your heart health, your brain health, your sperm health, your erection health. It's pretty much all the same common denominators, right? So anything that's good for what I always tell my men with erection is, anything that's good for your heart is good for your penis, right? So you want to make sure you're exercising. You want to make sure that your diet is good. You want to make sure that you're not taking a lot of toxins. You're not drinking too much. You're not smoking. Not a lot of drugs. So it's really common sense. When it comes to specific sperm things, when you're actually actively trying to conceive, then you don't want to be in a sauna or a jacuzzi. And again, the average man, from the time the sperm start dividing until he ejaculates them, it's a continuous process. It's like a cookie factory. It's about 3 months. So you can't say, oh, my wife is fertile this weekend, I'm not going to smoke for the next 2 days. That doesn't work, Same thing with anything that you're doing. So you at least
should really be thinking, if they're going to start family planning, they should sort of start to avoid or make some changes at least 3 months ahead of time.
Yeah. And the more the merrier, of course. And also, just obviously, a lot of people are becoming older parents, so you do want to make sure that you're taking even better care of your health, so that you are parents for as long as possible.
As I know, yeah, it's so interesting to me because I feel like as we're growing up, one, it's like this fear instilled in us that you can so easily get pregnant, and then as someone that struggled with fertility, you learn way more about kind of how everything has to come together for that to happen, and it's not as easy as they tell you. And then I also think there's this narrative that's okay, when you're ready to start a family, you'll be pregnant. But there's so much to do, and you can do to prepare ahead of time, like the 3 months ahead of time, making some changes for the men, certainly changes women can make, maybe 3 months ahead of time. It's almost like you said, you can't just decide in a day. For some people, it happens that way. For a lot of people, it doesn't. And just to have this information.
Right. The older you are, look, again, in my little black and white way, just like the woman gets to decide how many children, I am not a great believer in putting off having children. So again, you have to, once you find the right partner, if you look at each other, it's like, this is who I'm having children with, then have your children. Like on the sooner side, there is no good time to have children. It is always a stupid economic decision. It is always going to ruin your sex life or have a very negative effect. It's a dumb decision in terms of so many other parameters of happiness and wealth. But I can't imagine, personally, I'm one of those people, I can't imagine not having children. And it was like, once you decide on the partner, then as soon as physically possible, have those children. I literally want to pull my hair out, and I'm not very nice about it. Like when the couples come in and like she's 41 and she says, well, I don't want to be pregnant at my sister's wedding, which is 9 months. And I'm like, each month is really precious. Be pregnant at your sister's wedding. You'll be glad you did. It's like there's just many, many reasons why people will decide. I mean, I literally had someone come in, she's 41 and this is her second marriage, and she did not want to be pregnant at her son's high school graduation. And I'm like, okay, like you've lost me at don't want to be pregnant at anything but, high school graduation.
Yeah, you're sitting in front of me. So yeah, the time piece, the two things that you just said here, the time piece carries a lot of weight, and also finding a partner. Yes. As someone that has worked with so many women as a therapist, myself included, not meeting my partner to 34, that's become a real challenge for people. And also what you're seeing too, and again, most beautiful way, is there are a lot of women choosing single motherhood by choice, and because they haven't found that partner, and because they feel an age either where they feel that time crunch, or they feel at age ready to do that. But the finding the partner piece has become, I feel like, even more difficult for people.
Right. No, and that is really my heart goes out to anyone who's having any problems with fertility or life, but it's a very different equation. The women who haven't found a partner, and which is a lot, then they're in a different boat than the women and men who found their partners and then are delaying having children for legitimate reasons, but ultimately they're taking a significant risk that they may not be able to achieve their goals. Mm-hmm. I mean, we got married. I mean, I've always been in a rush, and so we had 4 boys in 5.5 years because we thought we thought we wanted 6, and my wife was 30 when we had the first one, and in those, so if you want 6, then you better be in high gear. And, for us, so we really had, between training and 4 boys, we literally had no life for the first, 25 years we were together. But then by the time the kids left the house, we were 52 and 54. And so
young, yeah.
Right? So I'm not saying, look, we're lucky we found the right person early, right? But I do think there's a value, and then I will stop pontificating, to assume that there has to be really, really good reasons not to have your kids on the early side.
Yeah. I think that there are, I don't think anyone, I don't know, sometimes that's the way that, at least I can speak specifically to my own experience. Like, I think that's the way that life just kind of played out for me. And I value the way it played out. I mean, if I had to choose, I don't know if I would have been a mom at 40, but I didn't meet my partner till later. And now I just try to look at it like I'm a better mom for it because I'm more established, I'm more patient, et cetera, et cetera. I'm not sure, anyone really, I don't know. I guess everybody's different, but chooses that.
Right. Look, it worked out for you, but it doesn't work out for a lot of women.
Sure. And I think the more, and this is why these conversations are important, the more information we have, I think the more informed decisions we can make.
People get to make their own decisions. They just have to be informed decisions. I have to realize. But the other thing, look, I am a great believer that being a parent is raising a child, not necessarily being their biological parent.
1,000%.
So I'm a great believer in donor egg and donor sperm. Now, that is not everyone is open to that for religious reasons, for, I would say that over the years, my most grateful patients have been the men who I have over time convinced that they would be very happy being parents, even if it's not their biological kid, and they're against it. And then you hand someone a baby, it's pretty hard to not love a baby, and it's your baby, and that baby wouldn't have been there if you hadn't willed it into existence. Mm-hmm. And those men are like, how did I even think about not doing this, and so.
Yeah, again, I think there's this huge emotional component. And I think there's also, visions of ways we imagine things. And if they don't go that way, it's very difficult to let go of that vision. But it doesn't mean another vision isn't as beautiful. And we've had so many women on here talk about their donor egg experience. And there's no difference. One of the guests said, this kid is mine through and through. And so it's amazing to hear that you have male. No,
I remember at the very beginning of my practice, I had a guy who had very, very low sperm count, and that was before you could do ICSI. So I literally, I started my practice as ICSI was coming into to the States, right? So, and it was only available in the New York area at Cornell. It was like one place.
What year was that ICSI was started?
It's a good question. It came to the state. Well, I opened my practice in 94. And at that point, the only place that ICSI was being done, certainly in this area, and I think in the country, it started in Belgium, was at Cornell. And there was a 2-year wait list. Women would put themselves on the wait list so that their sisters could do, it was just an insane situation. Wow. And doctors would be sending me patients, and I would have to say, unfortunately, it was not good for I felt badly because this doctor is sending me the patient and I'm sending them to another reproductive endocrinologist because they needed that. But I remember I had one guy that they did donor before ICSI was available. And then they were perfect candidates for ICSI. And he looked at me, he said, I have this perfect daughter. Why would I go through all of that? We're just going to do donor again. And you see that, the biology really falls away once the children are there. So.
I love that. I want to ask you about another narrative that's out there and get your thoughts on this. But you've seen some things. I don't know how true this is. And maybe this is I'm sure there's many myths when it comes to male fertility and fertility. But there's a narrative out there that by 2050, men won't have any sperm.
Yeah, that narrative has been out there since while I was doing my training. So that was 30 years ago. And there was that whole idea that sperm counts are dramatically dropping. There was a report from Sweden. Then there's the whole idea that it was bioplastics, and they would show you pictures of salamanders that were male with, it's so we don't really have good evidence that sperm counts are dropping. I think men are, again, I'm not harping on this, but men are older, and we know sperm counts go down as you get older. But in some ways, a lot of men are healthier than they were before. They're not smoking. They're exercising more. They're taking better care of themselves. Yeah. But a lot of them are older. So you're fighting those two trends. But there hasn't been, if there's been a drop, it has not been dramatic. And we would have seen a much larger trend in the last 30 years that I've been doing thousands of semen analyses, literally.
Okay. No, that's so reassuring to hear. Yeah. I have a 4.5-year-old son, and you hear this narrative and you're just thinking there's all these toxins and all these things and you're just like, oh my gosh, what do we do? I want this kid to have an option to have children if he wants.
We're all worried about the world, and we're worried about, the environment and people's lack of concern, for it and what's going to happen. Interestingly, sperm counts are pretty resilient, and many women don't need a lot of sperm to get pregnant, so it's, I can't say of all the things that I worry about that's even on, it doesn't make my list in the current environment.
Okay, that's reassuring. That's certainly reassuring to hear. Yeah. In all the years that you've been training and in practice and had your practice, have you seen like this being destigmatized, male infertility, and the level of comfort with men being able to talk about it and maybe look into it, acknowledge, accept that maybe that's part of the factor of infertility in their couple dynamic?
Definitely. I'll give you a more interesting example. So when I started my practice, makes me sound very old, but I am very old. There was, first of all, it was pre-internet. And it was pre-Viagra. So no man actually had ever talked to another man who was having erection issues. And every man thought he was the only one, because in modern culture, it was inconceivable that anyone would ever have at any age an erection issue. So I used to have to advertise in the phone book, and every man would come in thinking he was the only one, never having talked about it with anyone else. Now the men come in. I have whole, not police departments, fire departments. They're talking to each other. The cabbies are talking to each other. The brothers are talking to each other. The fathers are talking to their. It's like, it's so destigmatized. People get it that if you live long enough, you're going to have erection issues, and if you have a penis, we can get you an erection. So, like, why are we putting this? Why are we hiding this? So that has really, there's a lot more openness among men, certainly about sexual dysfunction. They're talking about testosterone. They're talking about those issues much more. I think fertility is much more private. The interesting thing with donor sperm is that all of the studies show that the children come out psychologically perfectly. There is no issues, the narrative being, always age dependent, but just like adopted children know from day one that they've been adopted. All the studies show that if the kids who are born through donor egg or donor sperm are know from the very beginning, and there's no family secrets. Grandma knows, Uncle Joe knows, we're not like, that they're fine. They're really fine. Daddy didn't have any seeds. He borrowed them, and, we were born and we wanted you. They turn out fine. When they don't tell the children, when it's a family secret, it's a nightmare. And all the studies show those children don't do well, and so it's fascinating. That's a hurdle. Sometimes the hurdle is not getting the men to use donor sperm. The hurdle is to getting them to communicate with their families that that's the case. And so I have to refer them to like Resolve or other organizations that really have, discussion groups and forums and things like that.
What do you think is like a few of the reasons it's difficult to share that? Is there shame? Is there narratives around like, I failed? What makes it difficult for them to make that decision then, but have a hard time sharing it with family?
Well, I think, you see women who also don't want to talk about the fact that their babies are from donor egg. I think that grandma may not be as connected to this child because it's not, she may be in a different place than the mother is,
Yeah.
And you come from a religious family where, that's adultery, which it is in certain, very, religious sects who will, almost every ultra religious sect, Jewish, Christian, Muslim, will not use donor. So that I find. And so that and if the children do, then they can't really tell the parent, it becomes very problematic. So, in certain family structures. And so it depends on, where you want to go with that. So
you're like doctor and counselor / therapist for.
Well, yeah, I was going to be a psychiatrist. I had a position at Columbia, and as you can see from this conversation, I love telling people what to do way too much to be a therapist. So I just want to tell them what I think, I don't want to have them figure it out themselves, so, which can make me, either people love me or, then I'm a lot. So it's okay.
What are some other, would you say, maybe misunderstandings, harmful myths, misinformation out there about male infertility that you would like to address or talk more about or have more open dialogue about, just to kind of, create actual like information that's valid and correct?
Well, I think that I would want to focus first on the men who have no sperm in the ejaculate, because I think that that's the most complicated field and the most evolving field in male infertility. And whenever we get those men, which is more and more, the question is, how do we manage them? But so if a man comes in and the semen analysis shows no sperm, that does not mean we are finished. Sometimes we can find a reversible cause. Sometimes either they've been put on testosterone or they have a pituitary tumor that's causing too much prolactin, or so we can try to see if there's something that's correctable. Then we can try to do things to try to see if we can get them to even have a few sperm in the ejaculate, because then we can work around that with IVF and ICSI. The procedure that we brought actually from Israel is called extended sperm search and microfreeze. And basically, a lot of the men who are told that they have zero sperm in the ejaculate have just very, very, very few sperm. And then the question is, can we find them and preserve them? The analogy I give is if, in general, if you have a lake that's just full of fish, you put a scooper in, you're going to be able to see that there's a lot of fish. If there's 8 fish in the whole lake, you're not going to find it with a scooper. You have to literally drain the whole lake and like search around the muck on the bottom all day, and then you're going to find your 8 fish. So that's what we do, and then we can freeze them. So the zeros you want, and then if we don't find sperm there, then some men will actually have low levels of sperm in the in the testes, even though they're not in the ejaculate. And then we can go and get them. So I think, again, just like with women, it's really important that you go to true specialists. With men, it's, you don't give up until a true specialist has told you to give up, So we definitely are moving a lot, on that front. The other thing that I would say, I'm sort of twisting the question a little bit, but one of the things that upsets me the most, as I said, we are like the world's experts on vaginismus, which is a fairly common phenomena where women cannot relax the muscles surrounding their vagina, and so they literally can't let anything in. So they, let alone a Q-tip, they can't put a tampon in, and of course they can't have a speculum exam or a penis, in their vagina. And bizarrely, instead of addressing the vaginismus, a lot of those women go right to IVF. And it's like insane to me. And we have a procedure, which is not really that brilliant. It's just obvious, where we actually bring them in, we put them under deep anesthesia. This is fascinating to me because this is not, this becomes biological at a certain point. Like if you have a knot in your neck, at a certain point, you're not gonna be able to massage it out. It is like literally in spasm. So we put these women under anesthesia. Even under anesthesia, they are pushing. The resistance that they have, they're literally, the anesthesiologists, the first time they do these cases, are shocked at how deep they have to get these women because they are pushing. Wow. We dilate them up, and then we inject Botox into the muscles, so that, then at a certain point they wake up. And these are women who really have a concept. It's like if I told you you had to push your baby out of your nose, right? It's like they can't imagine that anything can go into their vagina, and then they wake up and they have a big dilator there. They're all crying, and then they can go and they can have children naturally, let alone they can have a sex life and things like that. So, it's very frustrating for me that a lot of times the treatment for vaginismus focuses on infertility and just a workaround rather than giving these women a normal sex life. So
I have to say, you're teaching me right now. I didn't know about this, so I imagine there's so many women that are not informed that this is.
it's a huge number. And, sometimes I will see them come in on the men's side because the men will say, I'm coming in with erection issues. And then I see that they're having perfectly good erections, but they're literally hitting a wall when they try to go into the vagina, and it's a wall of muscle. They're just like, they can't relax it, and so sometimes you can do a simpler, procedure. Some of the women can be taught, outpatient, everything's outpatient, but they can just be taught to dilate, so it just depends. But they have these, vaginismus has classifications and they're called Lamont, and the deepest one is like, literally they call them table jumpers. Like they're on the table, you get close to their pelvis and they jump off the table. They literally,
Wow.
it's like this, it's become this thing, and
just, it's so unfortunate again, just lack of knowledge and information, as I can imagine, and we all, especially women that go for, through infertility. And I'm sure men hold these narratives too, like that we're broken or something's wrong with us without knowing that there's like a real medical issue that can be treated and resolved. And so
easily, that's what drives me crazy. It really drives me insane, And
I just wanted to back up to one thing you were saying in terms of like treatment for men. I'm just curious in terms of like in relation to treatment for women, whether it's like IUI or IVF, like cost and invasiveness. Like what is the cost of these treatments for men and how invasive? And I know there's a stage of them similar to women. But are some of these things costly? Are they invasive? Are they uncomfortable?
Yes, and yes. Okay. So, look, I have limited empathy for men who say, like, I really don't want to ejaculate into a cup. And I'm like, no, I understand when men can't, right? Because so then they can go home and do it. There's very few men who can't masturbate, and so I'm embarrassed. It's like, it's like, look what your wife is going through. So, it doesn't, I feel badly when they don't have a great semen analysis, just like I feel badly for the women who are subfertile or have premature ovarian failure. But, it's like, this is a very low price of entry is the embarrassment of producing, a specimen. So, I'm sorry. So but in terms of if you have to go in and you have to go into the testis to get the sperm, which is called the microscopic testicular sperm extraction, which has to be done by a true expert, then it's painful. More and more is being covered by insurance in some of the more progressive states, and even mandated, like, for example, in New York, after, a plan is a certain size, that it be covered. So just like IVF is now covered way more than it used to be. So when I opened my practice, it was never covered. The only place that it was covered was if you worked for Westchester County. So I literally had people who changed their jobs so that they could get their coverage, because it was so expensive. You had people doing second mortgages on their house. You still have that, but most of the time, it is, much of it's covered, and that's made a big difference in terms of huge. You don't want people to start their lives, in debt because of what they had to go through to have a child. Wow. To me, it's like we pay for, again, my opinionatedness, not a word, but, we pay for dialysis for 92-year-old people with dementia, and we don't pay for IVF for 37-year-old. To me, it's like, I don't get the equation.
I'm with you. I'm completely with you. Anything else? This has been so fascinating. I have learned so much. I'm so excited for our listeners to hear all this. Is there anything else that you'd want to leave the audience with? Maybe it's men not even thinking about children yet, or something they can do to preserve their fertility now, or just any other
one of the fun ones that I think is often overlooked is that a lot of men will start having problems with erections and ejaculation when they have to be on a schedule. Right. And there is this idea that you're supposed to have sex every day for like 2 weeks, which is almost physiologically and romantically impossible. So the studies show you should have sex the night, of ovulation, and then one more time 2 days later, and you're good for the cycle. But we have lots of men who, even with that, can't produce a specimen. And we have this idea that the way to conceive is by ejaculating in the vagina. Obviously, that's a little more romantic and more typical, but there is nothing magically magical medically about men ejaculating into the vagina to have a baby. The sperm just have to get there.
Yeah.
So I would say I have at least 500 babies in my practice where the couples have just done simple self-inseminations. So he ejaculates into a cup instead of into the vagina. It comes out goopy and sticky, and then there are enzymes that break it down. He keeps it at body temperature, basically holding the cup in his hand. You take a syringe, no needle, turkey baster, put it in the vagina, boom, baby. Yeah. So
really,
yeah, it's called self-inseminations. It's when you say it, it's like, well, that's a no-brainer. But literally, and sometimes, of course, just knowing that they have that as an option takes so much stress off that they don't even have to use it. But I would say conservatively, I have about 5. I mean, we have little packages. I just pass out the syringes. It doesn't have to be sterile, right? Sex is very not sterile, you know. And so just remember, if you're having problems, you can bypass it. And as you will attest to, there's very few people, when I look at each one of my children, I don't think about when they were conceived. There's been too many dirty diapers and sexless nights to have anything romantic about, you know.
No, I mean, and to your point earlier, like, especially couples or people going through this, like the desired outcome is the baby. I think it gets to a point where you don't necessarily care how the baby gets here. It's like once the baby is here.
Right.
Well, thank you so much for being here. This has been such an informative conversation. It's been a reassuring conversation. I love so much of what you shared is that there are so many things that we can do before we arrive at IVF. And I think, again, the more that we can empower people with knowledge and information, the better. So thank you. Thank you so much for being here.
My pleasure. I enjoyed it.
If you're someone struggling or relating to the topics that we're talking about now, and you're feeling the anxiety or the stress or the pressure of feeling like you're running out of time, you're behind, and you want some extra support, check out my group therapy practice in Midtown Manhattan, NYC Therapeutic Wellness. We have an amazing team of clinicians ready to support you in your journey, to help you feel more grounded, to help you feel more grateful, to help you feel like you're just exactly where you need to be. So check us out at www.nyctherapeuticwellness.com. Hey guys, I'm Beth. Thank you so much for tuning in to Quiet the Clock. If you want to hear more episodes and learn more about how to dismantle societal timelines, live life on your own terms, live life fully and authentically, subscribe to our channel on YouTube, and you can also follow us on Instagram and TikTok at Quiet the Clock Pod. You guys, I'm really excited. We just created all this amazing merch. And so if you're loving the podcast and you want to support our cause and continue to hear amazing episodes, please support us by buying some merch. I am living in these sweatshirts every day. We have a range of colors. We have hoodies, we have mugs, we have hats, we have journals. We have all of the things, and I love having them on because it's just a reminder to quiet the clock, to slow down, to like let life unfold and be happy. So there's meaning and purpose behind wearing it too, which is a nice reminder. So check out our website, quiettheclock.com, to get your merch. If this episode resonated with you, I would love for you to give Quiet O'Clock a follow. We are on all streaming platforms, Apple Podcast, Spotify, Amazon Music, and YouTube. Like, follow, subscribe. Please leave us a review. Continue to join us for conversations on how to rewrite your own timeline and live life on your own terms.